Okay, everyone, we're going to go ahead and get started. On behalf of all of us here at Medical Advantage Group, I'd like to welcome you all to today's webinar, Integrating Behavioral Health into Primary Care. Our speaker today is Richard May. Before we get started, I have a couple of housekeeping things that I'd like to cover. First is we're going to keep the phone lines muted during Richard's presentation today. We will be stopping towards the end for questions, so if you think of questions as we go, please just use the GoToWebinar little control panel and submit your questions there. We'll pause at the end to answer what we can. And then, as always, after our webinar, all registrants will receive a copy of the material as well as a link to the webinar recording. I'd like to just briefly introduce Richard. We've done a number of these behavioral health related sessions with Richard over time. Let me just quickly introduce Richard. He's the president of Strategic Integration Solutions. He has over 35 years of senior level management and administration experience in the healthcare and human services field, especially as it relates to behavioral health in acute care hospitals and outpatient rehabilitation. Richard's firm, the healthcare consulting firm, specializes in the integration of behavioral health and other clinical service lines with primary care. So with that, Richard, I'll turn it over to you.
Thanks so much, Bill, for the introduction. If we can go to slide 1, please. We'll start there at the top and proceed on through this series that I hope you'll find enlightening and effective for making decisions about the process of integrating behavioral health into your primary care practice. So if we can go to slide 1, the introduction.
Is that this one, Richard? Why you should want to do that?
It's the cover page.
Oh, I'm sorry. Gotcha. One sec.
There we go. Okay. As you can see, the purpose of integrating behavioral health into primary care has two goals. At least the model that I'm working with has these two goals in front of it for the introduction of behavioral health into primary care. As payers move rapidly towards value-based payment, and including the federal government through CMS, and particularly their CPC Plus program, integrating behavioral health is sweeping through the country and physician practices, albeit at a slow pace in some areas, but the CPC Plus program is certainly going to expedite that pace. So the goals are to improve clinical quality outcomes and to reduce the total cost of care. So when you think about just that very brief summary of why we want to do this, who wouldn't want to see those two goals achieved? Slide 2, please. But today, we're not going to go into the in-depth pieces of what the process entails to actually integrate behavioral health into primary care. We're not going to look at each component and the process in detail. Instead, as you can see from the learning objectives, what we want to do is what is required to successfully integrate a new and different service line into your practice. How's that decision going to be made? And we want to understand what that term of clinical integration of behavioral health really means. Next slide, please. This is probably going to be one of the more important decisions that you will make for your practice. It's going to impact how you practice medicine, how your patients respond to this new service line, and importantly, how your payers respond to what you're doing as well. But what I've seen in my experience is your physicians and providers are going to realize improved satisfaction in seeing their high-risk patients are really getting better, that the effort is really paying off. And the first practice that I installed this model at was in internal medicine. And after a year, the practitioners all said that while they thought they had a good handle with the traditional model of providing medical care, this model now allows them to practice medicine the way they really enjoy. The patient satisfaction increases as the level of wellness improves, and you make a real positive impact on the total cost of care, which is what your payers are looking at you to do. Next slide, please. Say if you're really thinking about integrating behavioral health, I strongly recommend that you take this approach, because it's going to help you achieve the benefits of whole person care. And the reason why it does is because we know from watching daily news that untreated, undiagnosed mental illness has a large human cost. There's a significant cost to society and to our financial system as well, with lost productivity, absenteeism, and you've heard the term presenteeism, where people are actually at work, but because of mental health issues, be it depression, anxiety, bipolar disease, they're at work, but they're not really there, functioning the way you want them to in your organization. So we're going to take a look at these three factors first before we get into more of a definition of clinical integration of behavioral health and how you go about making that decision. So first, we're going to take a look at the human cost. Next slide, please. I want you to focus in on these two circles here. On the left, the 29% is what one study produced that said 29% of adults with medical conditions also happen to have mental health conditions. And I believe, from my experience in conversations with primary care providers, that 29% is low. You've probably seen that perhaps in your own practice. Actually, from my experience, it's 40% and upward. But let's just say it's close to 30% here. If you have a practice with several thousand patients on your panel, even if it's a single practitioner of 2,000 to 3,000 patients, that means several hundred patients in your practice also have a mental health condition. And as you can see on the right, 68% of adults with a mental health condition have medical conditions. So there is an interlocking relationship, a very close interlocking relationship between the impact of mental health and physical health on the patient's quality of life. Next slide, please. Here I'd like to, for you to take a real close look at these graphics, because it's going to blend the human cost that I spoke about earlier and the financial cost. As you can see on the far left, a third, when we have high-cost patients that are going untreated, that raises the cost of care by at least a third compared to other high-cost patients. The second graphic, though, is something that I want you to call your attention to, because it's pretty profound. Half of all mental illness begins by the age of 14, 3/4 by the age of 25. So let's think about that a minute. Without early intervention, as your patients age and start experiencing physical health problems or existing problems get worse, they are likely to be struggling with a mental illness as well. So we can see that early intervention has a long-term positive impact on the quality of life of the patient by managing their physical and mental health conditions early on in life, and it does reduce hospitalization and utilization of other high-cost services. 79% of high-cost mental health patients were under the age of 60. That includes the very young and those approaching senior citizen age groupings. Next slide, please. Here we're going to look at the financial impact. This is one graphic that shows what we were talking about in the previous slide. I suspect that in your practice, diabetes and hypertension are probably in the top 3 conditions by volume, chronic diseases by volume that your practice has. So if you look at the right side of that graphic, you'll see the impact on financial costs to the healthcare system. But we have to keep in mind that not only is there a financial cost, but we have the human cost of a poor quality of life, the impact on family members, caregivers, their work environment, and society as a whole, as some of the reports we see on an all too frequent basis presents us with the fact that untreated mental health illness can produce profound violent impact on our society, let alone the financial cost. So we have to make sure we make that connection between the human cost, the cost to society, the cost to business, and to the healthcare system. Next slide, please. This slide is similar to the previous one, but it spreads the cost graphics over more co-occurring conditions. And you can see on the far left of each chronic disease that no co-occurring condition, the cost is much lower than as we proceed through substance use disorder, co-occurring mental illness, and co-occurring mental illness and substance use disorder. So there's no question that when we look at the human cost and the financial cost, this is something, again, that I really suggest your practice should consider because of the impact that it has for your patients and to the healthcare system. Next slide, please. One thing I believe it's important to consider is that the co-location of a behavioral health specialist in your practice does not necessarily mean clinical integration is being achieved. While it is a good step forward to do that, clinical integration takes on a much broader base than just simply the co-location of either a mental health professional on your site, and some mental health agencies have primary care providers at their site. But again, it's a very good first step. But as we'll see as we go through this discussion, it doesn't necessarily achieve what we wanted to achieve in terms of improving clinical quality outcomes and reducing the total cost of care. So what do we mean by the integration of behavioral health into primary care? Next slide, please. First, we have to define what a behavioral health specialist is. In my experience, I really focus on using independently licensed mental health professionals onboarding and embedding into primary care practices. These are generally doctoral level psychologists and master's level prepared independently licensed social workers or counselors that also have experience in multiple evidence-based practice treatment modalities. That is critical to achieving the impact that we need to achieve and the way this model is designed to be implemented. We also want to make sure that in addition to ability, that we have the proper personality fit into this practice. We know from experience that the field of medicine and primary care or specialists, providers, can have their own unique style of providing treatment and their opinions about how that is to be provided. Likewise, an independently licensed practitioner that's been in the business a few years is also going to have their thoughts on what's the best method for them to provide treatment to their patients. So what we need to be sure of, very important to be sure of, is that we achieve a good personality ability fit between the primary care providers and office staff, as well as the behavioral health clinician. I want to go back just a second to the experience and evidence-based best practices. Because of the volume that the mental health professionals are going to experience once this process gets moving, they're going to be seeing patients with serious medical conditions that are going to require them to use a variety of treatment modalities, including motivational interviewing, CBT, and other evidence-based best practice models to make a real impact on what we're going to do and how we're going to do it with this integration process. So I want to go into that a little bit deeper with our next slide on how that really functions. Next slide, yeah, here we go. How is the behavioral health specialist really going to function? And I want to camp out here a little bit on these as you have an opportunity to read through this information. It's very important that the behavioral health specialist is recognized by the primary care office and that they recognize themselves that they are part of a medical team. This is going to be different than hanging your shingle out in private practice down the street as a mental health provider. In this environment, you're going to be working shoulder to shoulder with nurses and medical staff, providers, in the care of their patients. So I want to focus on number 2 for a little bit here. The behavioral health specialist has to make an adaptation in their treatment modality and their line of thinking. They have to embrace the fact that they need to focus on the patient's medical condition and how their mental illness is impacting their health. But also, as we see that relationship intertwined, how their health condition is impacting their mental illness. It flows both ways. So as an example, as we look at item number 3, by and large, because of the volume of patients that are going to be experiencing some degree of mental health issues in your practice, like I said, if there's 30%, and you have 2,000 patients on your panel, that's 600 patients. So what we're going to focus on generally speaking, is the high-risk, high-cost patient, often those that are not compliant with their plan of care. So when we blend number 2 and number 3 together, when a high-risk diabetic patient is referred to the behavioral health specialist, the behavioral health specialist doesn't need to have a medical degree to know that diabetes can be a dangerous disease for people. But what they do need to know is they're sitting in front of them because the patient is generally high risk, as seen by the definition of the medical staff. So we've got to probe into why is that patient high risk? Why don't they want to get better? why can't they get better? And as we boil that down into a treatment modality, there could be family issues, a whole host of problems that are preventing that high-risk diabetic patient from controlling their disease. So what we want to do is spend some time with that patient, getting them to understand the serious nature of their disease. Generally speaking, in a mental health specialist in private practice could have an ongoing relationship with a patient for a year or even longer, seeing them once every 2 weeks or once a month. Again, here, because of the likely volume that you're going to experience as a behavioral health specialist, we want to try to see if we can adapt to more of a brief therapy model, where instead of the sessions lasting 50 to 60 minutes, which the initial session probably will, ongoing sessions will last more like 20 to 30 minutes, and instead of 15, 20, 30 or more sessions with a behavioral health specialist, we're going to try to shorten that down, again, by drilling in on the medical condition to maybe 6, 8, 9 sessions, something like that. So what we want to do is we want to stabilize the mental status of that high-risk patient, getting them to understand the nature of their disease and getting them to understand that how important it is to be compliant with their plan of care and work with their primary care provider to manage their disease better. Why are they hitting the ER 3 times a month? I've had a physician just tell me a week ago, a very serious cardiac patient of his goes to the ER frequently, not because of their heart condition and disease, but because they're anxiety-ridden. So what we want to do is focus on the reasons why these patients are classified as high risk. Next slide, please. So where do we start with the decision on, are we really going to go forward and launch behavioral health integration into our primary care practice? Well, you need to think about the data that we saw in the previous slides. And ask yourself a lot of questions. Include all of your staff in the office and have a very broad-based open discussion. In other words, encourage your office staff to speak out on what are they seeing with the patients. The MA, the LPN, the nurse, even the receptionist really could have a clear understanding and observation of the number of patients that they touch every day that probably could benefit from behavioral health screening using the TH29 or the GAD-7 for depression and anxiety screening. So include your staff, encourage them to express their thoughts on how this could be a benefit, and be very honest with your answers. That's very important. Don't try to color the picture in a way that doesn't make sense. So we need to focus on what we're doing and why we're doing it. Next slide, please. Next slide. Yeah, there we go. So what questions should we ask ourselves? First of all, do we really understand the direct connection between mental illness and physical health? From the data and the graphics that I provided earlier, I hope we can draw a straight line connection between mental illness and the impact on physical health, and conversely, the impact of physical health on a patient's mental condition. So do we really understand that finite representation between the two? And does your practice recognize that you really do have patients that experience mental illness and that their physical condition isn't improving. You're seeing the same diabetic patient over and over and over again, and they're not getting any better. Have you done that screening that I alluded to a minute ago to find out why doesn't this patient really want to get better? Sure, it could be socioeconomic issues as well as mental illness, and a combination more than likely. But what level of care in that case does your practice provide to those patients that you do recognize as having a mental health issue? Are you prescribing medication? Perhaps making referral to outpatient counseling services? And maybe even referring to a psychiatrist? We know today, no matter where you're located, in a rural setting or metropolitan, that it can be quite exasperating to get one of your patients seen by capable outpatient counseling staff, and even worse, to get them in to see a psychiatrist for evaluation and med management. So, next slide, please. We have to ask ourselves, what are the results that you're getting from that effort? Is it really effective? Or could we do better if we were managing those patients in-house by having behavioral health specialists on site? Would we be doing a better job for our patients if we have shoulder-to-shoulder contact between our primary care providers and the behavioral health specialists? Does it make sense to have the capability to do a warm handoff when we know a patient is really struggling in the exam room in front of us with mental health issues, to walk them out of our exam room and take them over to see an on-site behavioral health specialist? How receptive are the providers and the rest of the office staff to having a new and different service line in place? I can tell you from experience, fortunately it's been rare, that there is resistance at first, that they think they're managing their patient population just fine. We can make the referral and get our patients seen fairly quickly. However, we may not be getting feedback from the place where we refer them to on a timely basis. So we have to ask ourselves, this is going to be new and it's going to be different. Yes, it is going to require a little bit more work, not so much for the providers, but for the office staff in terms of making appointments, follow-up calls, and that sort of thing. So again, we have to ask ourselves very serious questions and give us very serious answers to those questions. Excuse me. Very importantly, does your system have good, reliable patient data? Do you have an EMR that can segment your patients by risk categories, stratify them into disease registries, really focus on those patients that are high risk, returning, not keeping their appointments, yet going to the ER or requiring hospitalization? Integration does require data. And as we go through the implementation process, the data becomes more and more important so that you can see, are the interventions that you're undertaking really working? And if they are, you can take that to your third-party payers to demonstrate that you're really making a difference here on reducing their cost. Also important is to ask, who's going to supervise the behavioral health specialist? And by that I mean some practices employ the behavioral health specialist, others contract with a behavioral health specialist. Whatever model is used, someone still has to work very closely with the behavioral health specialist on, are they receiving the results from the behavioral health specialist that they're needing? to make medical decisions? Are they receiving those results timely? Is there something more that they should be doing together to improve communications between the medical staff and the behavioral health specialist? So there's a real need to have someone that provides some oversight and direction, and the behavioral health specialist needs someone that they can go to with their issues as well. And here's one that's really important, is space. Many times, no matter what the size of the practice, space becomes an issue. Space can often be maxed out already with several exam rooms in use at the same time. But here I want to emphasize that the space we're talking about does not have to be a segregated area in your office where there's nice furniture and pictures on the wall. Certainly that may be good, but quite frankly, almost all of the situations I've been involved with this model simply use an exam room on the day when a practitioner isn't there. The patient is used to coming to that site. They're used to being in an exam room, so they're comfortable to some degree. And again, when the patient pulls up to your practice, no one is going to know if they're there for a medical issue or a mental health issue other than you, a couple of you, a few of you in your practice. So I think it's very likely that you have space available if we just spend some time discussing that when you would go down the road to implementation. And how will billing for this service be handled? Actually, there's several different models that we can use to handle the billing issue. Obviously, if your practice is going to employ the behavioral health specialist, you'll capture that billing up front, which is probably more prevalent than other models. Other models include where the behavioral health specialist is an independent contractor contracted with your practice. They may rent space from you and pay you whatever that rate may be for the amount of time that they're present. Generally, we start out with one of those two. There are some hybrid payment models, billing models that are deployed, but those are the primary two that we discuss. It's important, though, to deal with that up front. And again, primarily I'm seeing the behavioral health specialist employed by the practice. But again, that depends on the size of the practice. Can you really keep a person that busy full time? If not, then start out with perhaps contracting with them as an independent contractor. But in either place, usually on an independent contractor basis, we usually start out with the behavioral health specialist present 1 day a week. And that generally expands rather quickly over the next 2 or 3 months into 2 days a week and more. Even for the single practitioner office, it can easily be 2 days a week on site. What is your expectation for doing this? What do you hope to gain from seeing this? Well, perhaps you want to see a quicker turnaround of information that you get from compared to what you're getting now from referring to outpatient services. Perhaps you want consultation on medication, even though an independently licensed practitioner doesn't prescribe, in most states at least. They are familiar from their own experience in seeing the patients that are on various psychotropic medications and realizing which ones seem to work best in a certain case compared to others. Perhaps you want that capability to have a warm handoff for people that are in need of quick mental health intervention. So identify those expectations on what you expect to get out of this arrangement. Certainly, compliance with regulatory care delivery requirements it should be high on your list, especially if you're CTC Plus certified. And even under MACRA, embedding a behavioral health specialist on site does position your practice to be in better position to comply with both CTC Plus and MACRA, as well as a collaborative care arrangement, chronic care management. As I said earlier, value-based payment is leading us toward integrating behavioral health and primary care at a much faster pace than even a year ago. Another question to ask is, what will be the response of your patients? And I can tell you very matter-of-factly that your patients will really appreciate this, as well as their caregivers and family members. Oftentimes, the behavioral health specialist is going to meet with not only the patient, but they're going to have group conversation sessions with caregivers and family members as the proper treatment modality is identified. One way that if you're not CPC Plus and receiving the CPC Plus payment, you can monetize the integration of behavioral health into primary care, because your patients are going to get better, they're going to be more satisfied, they're going to keep their appointments, their visits to your practice, they're going to tell others of how they've improved their quality of life. So monetizing the cost is something that can be readily achieved over a period of time. Next slide, please. So your answers to those questions would really determine your readiness position. Write those answers down, and it should help you develop a set of action steps that lead your practice toward implementing behavioral health integration. And in fact, you may be in a better position to do this type of a project than what you realize once you start going through this initial assessment process. Whatever you do, take your time. Don't jump off the high diving board before you make sure there's water in the pool. Don't wing it. Don't make guesses. Again, hopefully you have good data in your EMR available to you that can give you an idea of the number of patients you have, for example, on psychotropic medication. Take a look at the number of patients that you have with an A1C of 8 or higher. If you're using the PHQ-9 screening tool for depression, summarize how many patients have a score of 10 or higher. That kind of data will help you boil down your answers to the point where you can develop an action plan on how you're going to make your decision, and when you make that decision to go forward, how it's going to be implemented. Take the time to get a plan in place. I know that writing protocols and policies and procedures is not anyone's favorite chore to do, but it helps to at least draft a workflow process on how this integration project is going to be accomplished. And here's what's very important, is to seek assistance from someone that's been there and done it. It will help break down barriers. It will help facilitate your conversation. It will provide some direction on what data to focus on, where you may be spending too much time and where you need to spend a little bit more time in making the decision process valid for your particular practice. So essentially, what we want to do is provide a direction for your practice and help you answer those very important questions, because as I said earlier, this decision is going to be one of the more important ones that you will make for your practice. And at some point, as the healthcare system keeps evolving, the integration of behavioral health is going to become, I think, from what I read and see, is going to become more prevalent than what we see today. I am very pleased to see that it is moving across our country and in various states, and that the payers are realizing that whole person care is really the method that's going to provide a reduction in the total cost of care. And the only reason why the total cost of care is reduced is because you're providing better quality care. Your clinical quality care outcomes will improve as the patient becomes more compliant with their plan of care. They understand their disease. They're working with their primary care provider. They're staying out of the ER, out of the hospital. One of the slogans, if I might digress just for a minute, that we had at Internal Medicine, where I opened this model several years ago, was "No more lost toes." And that came from a patient that we had that came to the practice during the winter, was severe diabetic, out of control, not managed at all. The first primary care practice that he visited never did a foot exam, never did any screening. Well, with our model, when we did those screenings, it was pretty clear that he had some really serious mental health problems and could have cared less, unfortunately, about his chronic disease. And he wound up losing toes on one foot. So we wanted to make sure that from a practice level, best practice method, that we were doing everything in our power to prevent that from occurring again, whether it's diabetes, hypertension, cardiac disease, whatever it might be. We can do more under a whole person care model than the traditional model. Next slide, please. So as we sum up, we've seen that undiagnosed and untreated mental illness does have very serious and significant costs on the human and financial side to our society, businesses, to families. So you need to ask yourself, is this something that our practice really should be doing? Could our patients really be benefiting from a whole person care concept? So you ask yourself those probing questions before you say, yeah, this is something, everybody's doing it, so we need to do it too. That's not the proper way to go about it. Develop a clear business case for doing it instead. Go through those questions that I gave you as examples. Include all your staff. Be honest with your answers. Look at your data. Your data will give you answers. And again, surprisingly, you may be more ready to go than what you think. Behavioral health clinical integration is a process. There are several essential components for it to succeed. All we touched on today was how to get to that decision-making position where you're ready to go down that road and take on a project of this size. And use the knowledge and experience of someone that could really help you, that can walk you through the process, will be there shoulder to shoulder with you to help you navigate the setup. How do you form an intensive care coordination outreach? What's a care coordination team look like? What's its function? What kind of reports are you supposed to be getting from your data system once you implement this? How are you going to demonstrate to the third-party payers that you are making an impact? How are your primary care providers going to react to having this new relationship in place? Essentially, what the answer is they'll see, and I can matter-of-factly state this, your patients are going to get better as a result, and your practice will be a leader in your geographic area compared to the traditional service delivery model. So with that said, the next two slides provide a reference for the data that I presented, and also my contact information if you would like to reach me. I enjoy my work with Meg in working with some of the SIPA practices and implementing behavioral health integration into those practices. It is a process. It takes time, but the payoff is well worth it. And I think the providers will second that comment. So, Bill, with that, this concludes my portion. If there's questions, I'll be glad to stay on the line and try to address those.
Okay, very good. We did have a couple questions that came in. I think some of them you've kind of answered just by going through all the questions the practice needs to ask themselves. Okay. But if I can kind of paraphrase, there were a couple questions around just how to get started with this. Let's say we've gone through the questions. We can convince ourselves, you know, this is something that we as a practice really wish to pursue. You know, how to operationalize it. Now, I know that you're helping any number of practices in Michigan start to roll this out, maybe in a pilot phase. Are there any anecdotes you could share, I guess, Richard, around you know, best practices or what some of these pilots have done that seem to work very well? Anything like that you can share?
Sure, Bill. It's a good question. First, we need to get the physician provider staff engaged at the very beginning in this process. They need to appreciate that relationship with mental illness and physical health. And many, many, many of them see it right in front of them every day. They tell me that they're exasperated because they can't make more progress with some of the more seriously ill patients. What we want to make sure of is that there's buy-in to take this step, that some of the medical staff are very surprised when the data starts being presented to them of the number of patients they have that are on psychotropic medications. They have a pretty good guess. They have a pretty good feel for it. But also when you start doing the behavioral health screening, that really provides a much clearer picture on the severity of those patients with mental illness, how serious their disease really is. So we start out by making sure we have a really good in-depth discussion on how we're going to work together, the behavioral health specialist and the primary care staff, on getting their patients' needs fully addressed, and how the mental health specialist will work with the primary care staff on getting them the information they need when they need it on a timely basis. And one of the things that I like to suggest is in conjunction with the behavioral health specialist, it's important to have someone in the role of providing care coordination, and along with that is some sort of a triage process, an algorithm, if you will, that will help the clinicians focus on those patients that need to be referred to care coordination and those patients that need to be referred to the behavioral health specialist. Not all of your patients with behavioral health issues necessarily need to be referred to a mental health counselor. So it's very important that we not get overwhelmed by the number of patients you may have, and instead look at the number of patients that are most likely going to benefit from behavioral health intervention.
Okay, very good, very good. Richard, as always, fantastic job. Thank you so much for sharing the information. With that concludes our webinar for today. I'd like to thank everyone for joining us. As I mentioned at the start, we will follow up shortly with Richard's materials as well as recording of today's session as soon as it's available. We thank you very much, and we look forward to seeing you again on a future webinar. Thanks, everyone.
Thanks, everyone.